Let's not do that. It seems to have some technical problems.
We are seeing the IRED slide now, Dr. Hafiz.
Yeah, that's right. There's something wrong.
Yeah, but for the time being, Amar, can you please release the attendance form, please?
All right, Doctor. All right, so I send the link in the meeting chat.
Okay, so let's get it out. Okay. We are on the system now. Okay, I think I should. Okay, Assalamualaikum warahmatullahi wabarakatuh and salam sejahtera, and I hope everyone is well. We have gone through the hypothalamus and pituitary. So today we are going to look at the hormones of the adrenal glands. This can change. Okay, so we are going to look at the learning objective. Is basically just only 3 because we are looking at adrenal cortex. So the first one I basically look at describing the gross anatomy and microanatomy of the adrenal glands, and then looking at the functional zone, innervation, and also blood supply. And then the second one, you look at the cortical hormones in terms of their chemistry, biosynthesis, origin, target cell, regulation or release mechanism of action. Okay, and then the third one, finally, you look at the action of glucocorticoid hormone in another one on Wednesday, tomorrow on Tuesday. Okay, so the next slide. We look at activity 3.1. That is the hypothalamus pituitary axis, and we know The first one is basically look at the three main axes of the endocrine glands. I think this one you already know, but I mentioned here again that you have three axes. There's hypothalamus pituitary, thyroidal axis, hypothalamus pituitary gonadal axis, and the one that we are going to look at is basically hypothalamus pituitary adrenal axis. Okay, which cell in the hypothalamus secretes the neurohormones that trigger the hypothalamus pituitary adrenal axis? Anyone? And what is this neurohormone is?
Chromaffin cell?
Yeah, no, the hormones, these are
CRH.
if you look at the cell, that means it's actually a neuron or cell body of a neuron, okay? And these are usually from the cellular, so they are the small nuclei cell, basically secreting CRH that trigger HPA, hypothalamus pituitary adrenal axis, okay? So CRH, corticotropin releasing hormones. What is the receptors and what is the tropes that is acts on the pituitary?
Acts on corticotropes and the receptor is the G protein coupled receptor.
Do you still remember what type of G protein coupled receptors?
GAS.
So G alpha S. Okay, so if you know G alpha S basically is going to activate the AC, adenyl cyclase, CMP increase, so PKA, they allow the release of what hormone?
ACTH.
ACTH. So ACTH is going to find its receptors. Where is it going to go then?
Adrenal cortex.
Adrenal cortex. So it's basically this is where you have these hormones coming down from anterior pituitary going to the adrenal cortex, right? Okay, so we are going to look at the activity 2. So basically activity 1 I think is done, right? So we look at activity previous one, sorry. Okay, so how is adrenal cortex involved in the hypothalamus pituitary axis? So basically from the hypothalamus, you have the release of CRH coming down to the release of ACTH, and ACTH is going to find the receptors in the adrenal cortex. And then from the adrenal cortex, actually they are divided into different zones, 3 zones basically. There is granulosa, fasciculata, and reticularis, right? So these are basically the looking at that. Okay, done. Activity 1. So activity 3.2, introduction to adrenal hormones. We already know the series of hormones that is affecting. We already mentioned the 3 axes, and you know each of the function. And then briefly describe the function of the hypothalamus as an endocrine gland and also as a neural control center in the central nervous system, and relate that with the stress response to the external and internal stimuli. I already mentioned saying that hypothalamus is actually the integrating center where all the afferent information go to the hypothalamus to be processed and integrated, right? Do you still remember what type of afferent information going to the hypothalamus?
Blood pH, PCO2.
Yeah, basically, you have the internal and also the external afferent information. Basically, the one that we know is osmoregulatory molarity, and you have the baroreceptor that is also going through the hypothalamus, which regulate the blood pressure. Right? You still remember that? These are mostly the internal the environment information. Okay, the external one, whatever that you feel, you see, you fear, these are all going through from the external source, and they are basically your normal receptors. They actually sense the external environment, such as your sight, okay, smell, even the taste. So that is going to go to the hypothalamus, okay. Once you activate the hypothalamus, this is where depends on which neuron or the nuclei that is being activated, basically is going to affect the hypothalamus to release neurohormone. Yeah. Okay, and we know there are a range of neurohormones that affect the anterior pituitary, and also two hormones basically affect going to the posterior pituitary. Okay, and you have okay, you have another one. This is the para or paraventricular or the pavi neuron that basically have a direct, basically going through the okay, from the hypothalamus directly going into the intermedullary cell. Let's see if I can pointer. Okay, you have here the paraventricular nucleus that going through and directly innervate on the intermedullary cell column. This is basically the sympathetic center, or basically sympathetic, the paraganglia that is present along the spinal cord and is present on the gray matter. Okay, the butterfly or the spinal cord starting from T1 until L3, basically L3, from T1 to L3. This is where all these so there are something what we call the sympathetic ganglion that is present along the spinal cord, and it's direct stimulation from the hypothalamus to this sympathetic ganglion, and then from there it actually go directly to the adrenal medulla, which we are going to do today also after this. Okay, so if you look at this is the spinal cord basically, and then the intermedullary lateral cell column is on the lateral side here. So it's shaded blue, okay, which is basically having a sympathetic outflow going to whatever cervical ganglions that is going through. But one of the neuron, the sympathetic neuron, that actually go direct and innervate the medulla. Okay. Any questions for this slides? Are you all clear? Before I proceed. No. Okay. There is another one. Basically, the neurons basically also released in the media eminent that release basically CRH and also affect ACTH release. We actually go to the adrenal cortex. Okay, next one. Function of the adrenal gland. So we are looking at activity 3.3, looking at adrenal glands and where is adrenal gland located. Adrenal gland is basically a very small pea size of about 1.5 to 2 grams glands that is located on the above the kidney. Okay, and we were looking at the blood supply, where is it coming from, and what is the significance of the two capillary network that connect the cortex to the adrenal. Okay, all this. Look at the next slide. Okay. So they are pea size. It has two different embryonic origin. The cortex is derived from the mesodermal tissue, whereas the medulla is a subpopulation from the neural crest, okay, which then form the chromaffin cell, okay, which actually release catecholamine in response to direct sympathetic stimulation. Okay, so the contribution of this adrenal gland to maintaining homeostasis is particularly regulating body adaptive to stress. So every time when you are stressed, this is where the neuroendocrine is being activated. The other one is maintaining of body water through aldosterone and also sodium and potassium. Sorry, water through ADH, and then sodium potassium regulate balance is basically through aldosterone, and also the control of blood pressure to basically regulating blood sodium and also water. Okay, so let me see. You have granulosa, zona granulosa. These have abundant endoplasmic reticulum. It only basically secrete mineralocorticoid. There's aldosterone. And then you have zona fasciculata. They have abundant lipid droplets, and these are basically a lot of cholesterol that produce glucocorticoid, and most important is cortisol. Okay, it also do produce some androgen, but most of the androgens are actually produced here in zona reticularis. Okay, so we basically divide them into three zones: aldosterone in the granulosa, that is the first layer of the cortex. Then the middle layer, the fasciculata, which is usually much bigger, and you probably will know that this is mainly to produce a lot of cortisol. Okay, and then you have the androgen that's produced at the reticularis. Then down here you have the medulla, basically to produce epinephrine and some norepinephrine. Okay, so all these are steroid hormones produced in the Okay, there's another graph to show you about the three different zones. Basically, sorry, the size, the adrenal glands, and then the shape of the adrenal glands, the capsule, and finally the zone, the cortex. Okay, and the medulla. Actually, the cortex is much bigger compared to the medulla, so this is not the proportionate drawing. Okay. Name the type of steroid produced by the adrenal gland and describe the synthesis in the cortical cell, and what controls the synthesis of the steroid hormones. Explain the mechanism, and do steroid hormones from the adrenal cortex exert their effect during stress? So how does that release affect stress when during stress? Okay, this activity is 3.9. Okay. Now we look at the blood supply. So the blood supply are basically coming from the superior branches of the inferior phrenic artery directly from the aorta and from the renal arteries. Okay, when you reach the adrenal glands, this artery branch into form a plexus under the capsule supplying the adrenal cortex. So you can see that they basically branch into many of them, and then they supplies the cortex. Okay, but from there, there are also direct branch that actually going down to supply the medulla. Okay, this medulla is also nourished by branches of supply from the central, also from the central vein. They also can actually supply that. Okay, so the capillary plexuses they actually have is basically two. One is to make sure that all the hormones that is collected, the steroid hormones, will actually flow through and to the central vein, and finally also bathe the chromaffin cell. That means the adrenal medulla. Okay. Then from the adrenal medulla, into the portal vascular system that arises from the capillary and finally in the cortex. There is also a capillary network of lymphatic that drains the plexuses around the central vein. So around the central vein, some of them are drained by the lymphatic system. Sorry, my one is okay. So this is a large picture to show you the diagrams on the blood supply from the medulla to the cortex. Okay. So from here, in order to be able to produce from the hormones, the steroid hormones from the cholesterol. So all these cholesterol are basically coming from your dietary cholesterol, which is basically from your food, and also some of the cholesterol can actually be from the cell membrane. And we know that there are a lot of cholesterol present on the cell membrane of the cell. Okay, so the biosynthesis, basically you have zona granulosa, fasciculata, and zona reticularis. In the granulosa, it basically only able to produce cholesterol because it doesn't have the 17 hydrolase. Okay, Whereas in the fasciculata and also fascicularis, they have this. So from here, the prednisolone cholesterol is converted to prednisolone, progesterone, and then it can be converted to 17-hydroxyprogesterone, and from there it can become cortisol. Okay, the same thing as zona reticularis. That's why these two zones can produce to a certain extent cortisol and also androgen. So aldosterone production, we look at activity 3.12 on aldosterone production. So what are the two major factors that regulate aldosterone secretion? Anyone?
Osmolarity.
Osmolarity of
High concentrations of potassium and angiotensin 2.
Okay, so the two major factors are angiotensin 2 and also potassium level. So if there is an increase in potassium level, it will direct stimulate the aldosterone to be secreted. Yeah. So describe the role of renin angiotensin regulating aldosterone. So you know that basically aldosterone, this renin is released from the juxtaglomerular that convert the renin itself is an enzyme that convert angiotensinogen to become angiotensin 1, and angiotensin 1 going to the lung to be converted to become angiotensin 2. Okay. Or before we go there, you say why ACTH is not the major factor in regulating aldosterone secretion? Okay, because ACTH basically is not, right? Here, hint is that although nemosyllase is stimulated by ACTH, pregnenolone cannot go through the form aldosterone because the enzyme, there's no enzyme, there's 17-hydrolase that's not there. So it doesn't actually able to convert into 7. We look at the previous one. Okay. From here, because there is no, so progesterone will be directly converted into 17-deoxycorticosterone. Okay, it doesn't go into 17-hydroxyprogesterone. So these are the process where it affected the aldosterone. ACTH doesn't have a direct effect on aldosterone secretion. Okay. Then why is cortisol not produced in the zona granulosa? Because of 17-alpha-hydrolase. Okay, and then describe mechanism of regulation angiotensin 2 and also potassium level. Okay, the mechanism of action, we'll look at it later. So mineralocorticoid synthesis and release is regulated by angiotensin 2 and extracellular potassium. So angiotensin 2, both of these basically increase the intracellular calcium concentration. Okay, angiotensin 2 is receptor is basically GQ, and we know GQ is going to activate PLC, and then IP3. IP3 is going to stimulate calcium release from the internal store. Whereas for potassium concentration, it depolarizes the cell, which basically activates the voltage-gated L and T type calcium channel that allow calcium to influx. Okay, both this mechanism is mainly to increase intracellular calcium that allow exocytosis of the hormones that is being formed. Diagrams quickly show you how this hormones aldosterone is being regulated, mainly based on the plasma potassium and also on angiotensin 2. Okay. There's another aspect, the regulation of aldosterone secretion. Okay. Receptor activation by adrenosteroid. And we know that mineralocorticoid receptors bind to aldosterone and cortisol with equal affinity. Moreover, the same, this activity 3.10, moreover, they have the same DNA sequence that also serve as a hormone response element. So the question is, how can aldosterone stimulate specific biological effect in terms of the kind of system, particularly the blood concentration for cortisol are something like 2,000 or even 1,000. basically the fasciculata zone are much bigger, which have more cells that actually produce a lot of glucocorticoid, more than aldosterone. So if you think about it, basically the concentration of glucocorticoid is much higher, and they basically going to find the same receptors, the mineralocorticoid receptors and also the glucocorticoid receptors, and they are going to bind to it. So if there is high concentration of cortisol, that means it's going to affect mineralocorticoid receptors and prevent aldosterone binding to its receptors. Okay, the answer is next one. Okay. This is basically due to the cell itself. One is the target cell, it express 11 beta hydroxysteroid dehydrogenase, which basically convert cortisol that bind to the receptor to become cortisone. Okay, and this will make it weak affinity for the mineralocorticoid. And the other one is also because this enzyme protect the cell. Some tissue in the liver express abundant mineralocorticoid receptor, so they actually have more. And I see if I can have another reason is okay. So if you look at it, the first reason is we say that mineralocorticoid circulation are usually bound to the cortisol binding globulin or albumin. So basically only very small fraction of the hormones is unbound that can cross freely to the cell membrane. So if you look at the cell, okay, this cell basically, most of these are actually bounded, so they are not freely available, so they don't really cross very much. So almost 95% of them are basically bounded, so very small amount are actually present. The second reason is basically hydroxysteroid dehydrogenase that convert cortisol to cortisone. And then the third reason is basically mineralocorticoid receptor can discriminate between aldosterone and glucocorticoid, whereas aldosterone dissociate from the mineralocorticoid 5 times more slowly. That means when aldosterone binds to a receptor, it dissociates 5 times less slowly, dissociate less compared to cortisol. So cortisol tend to dissociate faster. Okay, so these are the 3 reasons why, even though you have high concentration of cortisol in the plasma, but with low aldosterone still manage to get to its receptors, the mineralocorticoid receptors. Okay, so mechanism of action of aldosterone. So where does aldosterone actually works on? We can look at, describe how the ligands is released from the adrenal cortex and how it's transported. Receptor complement to aldosterone, and the name the drugs that use really able to compete with aldosterone, and when you would use this drug. Okay, so we look at the next one. Okay, the mechanical action of aldosterone are mainly on the distal tubule, principal cell of the distal tubule, and the collecting duct of the nephrons. Okay, so what does it do is basically this aldosterone is the receptor is present intracellularly, where basically it binds to the gene for gene transcription for RNA formation, basically to produce a lot of sodium channels and also produce a lot of sodium potassium pump. Okay, that allow the absorption of sodium. Okay, so it basically increase synthesis of sodium channels in the apical membrane and also increase synthesis of sodium potassium pump in the basolateral side. This allow the absorption of sodium through these channels. Okay. Did I go too fast? Anyone?
Yeah.
A bit, doctor.
Is it too fast?
Yes, doctor.
Is there any question you want to ask before I move on to cortisol or the problems of high or low aldosterone?
Doctor,
Yes.
just now there's one slide where you mentioned aldosterone will bind to a GQ protein coupled receptor, and in this slide it shows that it's binding to an intracellular receptor. Can you explain a bit on that?
There show slide bind to aldosterone bind to the intracellular
Yeah, I think
receptor
that
or the memory receptor.
there was one slide that shows aldosterone bind to GPCR.
I think that was angiotensin.
Oh, there's angiotensin
Oh,
2.
right,
It's not.
right.
It's not aldosterone. It's angiotensin 2.
Oh, right, okay. Maybe
I think
saw wrongly.
you overlook on it.
Yeah, right.
I try to go back to the yes.
I have a
Yeah,
question.
Jannah. Yes.
Pathway for cholesterol synthesis. Do we have to know the exact pathway and all the enzymes involved?
No, we don't really ask on the enzyme. What we're looking at is what are the limiting enzyme, rate limiting enzyme that is very important for the synthesis.
Oh, all right, thank you, doctor.
Yeah, you don't have to really memorize the whole process, but if you do, it's also nice to know. But you need to know which are the limiting steps, especially on the zones. Okay, that can be a limiting enzymes that limited the formation of the products. Okay. So if not, I will just move on to the next one. Okay, we look at Addison disease. Addison disease. Okay, this is activity 16.
Doctor, I think you're muted. Maybe you can press beside the camera. Can someone hear me?
Yes.
Yeah. No.
Where is Dr. Hafiz?
I can't hear him.
Doctor, your mic is muted.
Okay, sorry. Until now, starting from the beginning.
No, I think
Previous
Beginning
slide.
of
previous
Addison
slide.
disease.
Yeah, Addison disease.
Okay. So Addison disease, we just skip the one. We go, I think there's something wrong to the slide, so there's something jump out. We look at disease of overproduction of mineralocorticoid. Is that okay? So you look at the disease, so you have primary, secondary, tertiary, and even pseudohydronism. So for primary, basically, it's known as Conn syndrome, and is a condition where there's a benign tumor of the adrenal glands that result in hypersecretion of the aldosterone. When you have hypersecretion of of sodium, if your kidney will be trying to retain as much sodium in the ECF, so you will have water retention. This will increase in water retention will cause hypertension, okay? And also hypokalemia because of excess potassium secretion, okay? The release of renin is suppressed because you have a lot of aldosterone, which basically also suppresses renin secretion, and also because a lot of sodium that is present is suppressing the renin secretion. So this is known as Cone syndrome. Yeah. Then the second one, secondary hyperandrogenism that result on excess aldosterone production in response to renin-angiotensin system activities, which means that there is increase in renin-angiotensin system activity somehow stimulated by probably sympathetic activation. You can also activate a lot of renin being produced, angiotensin being produced that allow hyperaldosteronism. Okay, and then you have the tertiary. Very rarely you've seen them. And then you have the pseudo-aldosteronism, which is the excess mineralocorticoid activity caused by mineralocorticoid receptor activation by substance other than aldosterone. So there's overstimulation of the receptors. It could be due to some of the chemicals that we took in that actually cause high aldosterone effect. Okay, though there are three things: primary, there are four: primary, secondary, tertiary, and pseudo-aldosteronism. And then you have disease of under-secretion of aldosterone. These are the primary aldosteronism. There is lack of adrenal gland production of aldosterone, and this is known as Addison disease. Okay, Addison disease is due to destruction of the adrenal glands because of infection, injury, or autoimmune, basically injuries to the adrenal glands. So the plasma renin activity is elevated. So this condition is also known as hyperreninemic low aldosterone and also high renin being secreted. This is primarily hypoaldosteronism. That's Addison disease. And then you have secondary hyperaldosteronism. There's a lack of aldosterone production. Okay, and this is inadequately stimulated by angiotensin 2 despite normal renal function, and there is also a condition usually associated with renal insufficiency. I mean, there's something wrong to the kidney that can actually affect the angiotensin 2 secretion. So it's also known condition as hyporeninemic and also hypoaldosteronism. That means there's low renin and also low aldosterone being produced. And then the third one, you have pseudo-hypoaldosteronism and caused by unresponsive mineralocorticoid to the action, and this characterized by severe salt wasting and also hyperkalemia and metabolic acidosis. Okay, so you have under and over. So we go back to okay. So activity 3.16, we talk about Addison disease. So we already discussed the pathophysiology or sign and symptom of Addison disease. So you have hyperpigmentation, increased ACTH. There will be increased ACTH, increased melanin from the POMC. Hypotension, because there is low aldosterone. That's why the volume contraction due to low sodium. So you have hypoosmotic contraction. Still remember the year one physiological classes. And there is also a gastrointestinal problem, decrease in motility and secretion. Okay, and there is weight loss, GIT dysfunction or loss of appetite. Muscle weakness, reduced muscle function. Okay, and anemia, reduced erythropoietic production. This is mainly related to the kidney function. Yeah, so you have low blood pressure. And also you have vitiligo or skin problems, and mainly these are related to low aldosterone. That is Addison disease. Okay. Okay, before we go to cortisol, we want to take 10 minutes break. We'll start at 10 again. Say okay, unless you have questions. Everyone's still around?
Yes, that's okay, Doctor.
Yes.
Yeah.
So we take
Still there.
10 minutes break. We'll start at 10 after this break. Any questions so far? No? So we take 10 minutes break and we'll start at around 10. So it's around 30 minutes break. Is that okay?
Okay.
Start
Yes,
at
Ahmad.
10
Any
and
question? Yeah, we start at 10.
Alright.
Doctor,
Yes.
could you share the slides?
Yes. Which slide? The whole slide.
Yes.
Okay, I will email the slides after the class. Is that okay?
All right.
Yeah, actually, most of the slides I adapted from the modules that we sent to you, so you can actually read the modules. It actually helps to complement each one. Okay, I'll see you at 10 then.
Alright, Doctor.
So just to start, before we start, I just want to ask you, how are everyone doing so far for the endocrine block?
It's okay so far.
So far, it's okay. You all can follow the online sort of learning.
No choice lah, doctor.
No choice.
Don't really have a choice.
Yeah, same thing, because I find it odd also basically to try and who is actually paying attention, who is not. So it's actually quite difficult to do the online classes. Not like face to face where we can see everyone. Anybody under stress? Because there are a lot of cases when MCO, everyone is stressed.
Not stress lah, doctor. To relax, I see.
So you are at home, I believe most of you are at home, right?
I think there's not enough. There is not enough eustress. Like the good side of stress is not there.
Okay, so there's not enough stress or good stress.
Yes.
You will see tomorrow how the stress is going to affect you. Okay, so I think I can start now. It's already 10. So I look at activity 3. Stimulation of cortisol production. And this is where we look at the hypothalamus pituitary adrenal axis, where basically CRH is released by the hypothalamus, and then ACTH that stimulate pituitary, anterior pituitary to release ACTH, and this ACTH then basically go into your adrenal cortex to release cortisol. Okay, now where is cortisol derived from? So all the steroid hormones, they are coming from cholesterol. Okay, so what does ACTH do? Is basically ACTH acts on the G protein couple receptors, GS, activating adenyl cyclase, and these are membrane couple receptors, membrane bound receptors. So you activate adenyl cyclase. So adenyl cyclase basically increase it, that means it convert ATP to cAMP, and you have protein kinase A. What does protein kinase A do? Is basically to increase the activity of cholesterol hydrolase. So this cholesterol esterase hydrolase, ester hydrolase, CEH, basically increase this activity to convert cholesterol to convert the cholesterol, basically convert a lot of this one into cholesterol. So a lot of cholesterol to be moved into from the cytoplasm to go into the mitochondria to be converted into pregnenolone. Okay. Now, as by 17 alpha hydrolase, it converts pregnenolone to become 17 hydroxy pregnenolone. This one basically transit, it means you are from the cortisol, that means from the cytosol, we go into the mitochondria, and then from there, this is converted to pregnenolone, and then pregnenolone diffuse out into the smooth endoplasmic reticulum, and then convert into 17 hydroxy pregnenolone. In here, it's later converted to become 11-deoxycortisol, which means that the role of mitochondria is mainly to, discuss the role of mitochondria and cortisol synthesis. That means the cholesterol shift from the cytoplasm into the mitochondria, and then out into the smooth endoplasmic reticulum, and finally back again into the mitochondria before it diffuses out the cortisol that is formed. Okay, so this is the major role played by pKa in cortisol synthesis, mainly to increase the cholesterol esterase, ester hydrolase. Okay, so this diagram basically explains the whole of the questions that we asked in activity 3.14. Okay, The same thing, you look at the zone, now you look at zona fasciculata, cholesterol converted to here, phenylalanine, diffuse to the mitochondria. Come out again, go to smooth endoplasmic reticulum to become 17 hydroxy progesterone, and then convert to become 11 deoxy cortisol. Then it moves back again into the mitochondria to finally to become cortisol before it diffuses out. So this whole process that means transit between the cytoplasm, smooth endoplasmic reticulum, and then finally going back to the mitochondria again. Okay, so we talk about the axis, hypothalamus pituitary axis, basically working all this way. And cortisol itself have a negative feedback to suppress ACTH release and also CRH release. So cortisol itself have negative feedback to regulate its own concentration. So as the concentration of cortisol increases, it will negative feedback to reduce CRH and also ACTH. So regulation is closely regulated by ACTH and plasma cortisol level parallel to those of ACTH, which means basically cortisol regulates its own secretion. And there are three mechanisms that also control to neuroendocrine control. The first one is episodic secretion and also circadian rhythm. And we know that circadian, that means diurnal. At night, when you sleep towards the late part, that's where there's an increase. And then when you wake up, it reduces again, and then it starts to increase again. So there's diurnal rhythm, okay, based on circadian rhythm of ACTH release. And the other one is the stress responsiveness. That means stressor, hypoglycemic, hypotension, fever, trauma, all these can affect CRH release. Okay. If you are hypoglycemic, basically you are going to cause more CRH increase secretion, so ACTH secretion to increase, and then cortisol. And then there's a feedback inhibition by cortisol on ACTH. Okay, so there are three rhythms that actually regulate, or three factors that actually regulate the neuroendocrine control of cortisol secretion. So the circadian is usually, I already mentioned about the circadian rhythm, and then, stress responsiveness, the plasma cortisol ACTH basically respond to physical stress. So the ACTH and cortisol are secreted within minutes following the onset of stress, especially when you are hypoglycemic or when you have a fear, something like that basically activates the ACTH and cortisol release. Okay, and this will basically abolish the circadian periodic response. It means they override the circadian. If there is no stress, basically your cortisol level secretion is based on the circadian. That means the rhythm. Then the mechanism of action of glucocorticoid. As we know that glucocorticoids, the main function is basically to increase your glucose level, or actually it regulates the glucose homeostasis. Not really homeostasis, I would say it basically increases the plasma glucose level. So when stressed, the glucocorticoid cortisol is secreted, the plasma cortisol increases. Okay. Then how does this activate the receptors? Basically, all these glucocorticoid, they have glucocorticoid receptors. It binds to the intracellular receptor that operates as a ligand-activated transcription factor. Basically, it regulates the gene expression that affect the protein synthesis, ultimately responsible for the physiological effect, which means that once glucocorticoid is present basically in all our body cells, the receptors is present in all our body cells, what it did is basically it binds to the glucocorticoid proteins. So these proteins are basically enzymes. So it's basically enzymic function of the cells. Okay. So we can look at there are many different effects. You look at on the muscle, fat, liver, immune system, cardiovascular, renal, and many more. You can actually read all this. Okay, so the principal side of actions, like the brain, the endocrine function, what it did is basically suppress LH, FSH release. If you have high cortisol, GH secretion, and also TSH release. Okay. But on the positive side, cortical carbohydrate and lipid metabolism, it increase hepatic glycogen deposition, increase peripheral insulin resistance, increase gluconeogenesis, so that you can form more glucose and circulate into the plasma to increase the plasma glucose concentration, and increase free fatty acid production. Sorry, it's irritating my throat. So the principal side are basically all over our body. You can find the increasing cortisol level. The effect all the means all our body cells have glucocorticoid receptors. So in summary, mechanism of action of glucocorticoid, they are multi-systemic effect. Okay. The main thing is to increase the blood glucose concentration, and also it stimulate proteolysis, especially in the muscles. Glucogenesis, so the substrate of protein for gluconeogenesis to produce more glucose. Inhibit muscle protein synthesis, and also increase fat mobilization. That means it's going to move the fat to the liver for glucose. Metabolic result in loss of lean body mass. And the other one, it exerts an overall anti-inflammatory effect. This is where scientists exploit to use glucocorticoid as anti-inflammatory effect. So people who have inflammation, uncontrolled inflammatory problems, they can use this to control inflammation. Sorry, I have a cough. I just take a break for a while.
Right.
Okay, so far, any question about the synthesis of cortisol? Anyone, any questions? No?
Doctor,
Yes.
cortisol only, like, its main idea is to increase our glucose levels in the plasma, right?
Yes.
So if long term, there will be actually very bad effects, isn't it?
Yes. So now we look at the effect of high cortisol when there's oversecretion of cortisol. And I have mentioned that cortisol will increase when you are under stress, right? So in stress, basically it direct increase your CRH because it affect your hypothalamus to increase CRH release, and basically ACTH, which also increase of cortisol level. Yeah. And there is also another one direct effect that basically when you have activation of hypothalamus, you will direct activate your adrenal cortex. Adrenal medulla. That will result in increase in epinephrine. Plasma glucose level. Okay, this is what we call the fight and flight reaction to prepare your body for metabolism, increase energy requirement. So we look at the the problems of Cushing syndrome. Okay, so in Cushing syndrome, this is the effect of high cortisol level. So what does it actually? What is the sign and symptom of Cushing syndrome? You basically see people who have this problem: moon face, buffalo hump. That means you see the buffalo hump here. Okay, there's increased fat deposition, and then your central obesity. That means the obesity is only at the center, but thin limb, the arms, all this become thin. So this is because of increased proteolysis of the muscle that becomes substrate for glucose synthesis. Then you have hypertension, purple abdominal stripes. So all this striation damage to the skin by prolonged. So that's why abdominal fat basically increases. Okay, and then you have poor wound healing because of a decrease in immunological function. It means the wound that they have is basically poor healing. Now the difference between Cushing syndrome and Cushing disease. Okay, see if I have the slides. Oh, this is another symptom just to show you. This one, yeah. So between Cushing disease and Cushing syndrome, okay, Cushing syndrome is any condition regardless of the cause that cause the adrenal glands to produce excessive cortisol. So it's regardless of any condition, either due to increased ACTH or increase or tumor or anything that can actually increase or external source of cortisol. That means people who are taking dexamethasone as a supplement or something, then you can increase cortisol level, excessive cortisol level. So this is known as Cushing syndrome. Pituitary gland that cause the pituitary gland to produce too much ACTH and cause the adrenal gland to produce cortisol. And basically, it means that Cushing disease is one of the Cushing syndrome, but the main cause is primary tumor of the adrenal gland. Okay, so we can see the difference between Cushing disease and Cushing syndrome. Okay, so every people who has the moon face, buffalo hump, okay, central obesity, all these are the syndrome of Cushing syndrome. Okay, so in effect, the summary. So the effect of cortisol during fat stage are usually very minimum, but during the fasting state, cortisol contribute to maintain plasma glucose level by increasing gluconeogenesis, glycogen deposition, and also peripheral release of substrate. So hepatoglucose production is enhanced, okay, because our cortisol level will be high to try to increase the plasma glucose level. Okay, the effect on muscle is basic catabolic. So usually during fasting, we will lose around 2 to 3 kilos of our body weight because of muscle catabolism. And then adipose tissue, there's lipolysis. So in glucocorticoid deficiency, hypoglycemia may result, whereas in the state of glucocorticoid excess, you can cause hyperglycemia, hyperinsulinemia, and also muscle wasting, weight gain. So people who have hyperglycemia, you have to check either they are due to excess glucocorticoid and not really due to reduced insulin level or diabetes. So you have to be very careful on that. Okay, so this is basically to show neuroendocrine response to stress or during exercise. So we have this paraventricular nuclei will basically release. What to do is it's going to increase CRH, cortisol level. That is going to stimulate your ACTH release that affect the adrenal cortex to release cortisol. And cortisol can negative feedback. Okay, and you have a direct from the paraventricular nuclei that directly affect the medulla, adrenal medulla, through the sympathetic activation. So what does this effect? Basically to increase the glucose level. So you have increased glucagon, but decreased insulin. Okay, so in the liver, you have glycogenolysis, that means the breakdown of glycogen, and increase gluconeogenesis to increase glucose level. Okay, there will be more free fatty acid, okay, mobilization of free fatty acid also for gluconeogenesis as a substrate for gluconeogenesis. And then okay, so metabolic response to cortisol during acute stress. So you can, there's another slide, you can actually read that these are acute stress. We are going to do a lot during tomorrow about stress, acute and also chronic stress, and how does that system be activated to protect us or can become a disease. Then this is another one slide to show you about the chronic stress. Okay, so there's the summary of that. Okay, I'm done. Any questions?
Doctor,
Yes.
just want to clarify. The Cushing symptom and disease.
Yes.
So it means that for Cushing symptoms, it doesn't mean that it will have a Cushing disease. But if it's Cushing is going to have Cushing syndrome without any external.
Any syndrome that you see like Cushing syndrome, it included Cushing disease. That means anything that can cause an increase in cortisol level are known as Cushing syndrome. Are you clear? So anything, either external source, either internal source, I mean internal production, anything that can increase cortisol level is known as Cushing syndrome. Okay?
Oh, all right.
But primarily when there is an increase in cortisol specifically due to pituitary, that means due to increase in ACTH, that means there's a tumor and the cause of the tumor that release too much ACTH, and this is from the pituitary, then you call that Cushing disease.
Oh.
Okay.
So syndrome means that.
So the
it's
disease
kind of,
is part of the
disease too, right?
Yeah.
Oh, all right.
Cushing disease doesn't care about any condition. As long as there is increase in excessive cortisol level, you call that syndrome. Even the source can be from external source, not necessarily from the adrenal gland that produce excess cortisol. So it can be actually from external source. So you call that Cushing syndrome. That means you don't actually know where is the source coming from in Cushing syndrome. But if you specifically know that the source is coming from pituitary glands because of increased ACTH that cause high cortisol level, then you call that Cushing disease. Is that okay, Amar?
Okay. So it means, doctor, how about the clinical features? So both of them have the same clinical features.
They have the same clinical
It's
features.
It's
As
just
long as you have
the problem.
Yes, the cause.
The cause.
Yes, if you specify as Cushing disease. Okay.
All right, doctor. Thank you.
Doctor, could you
Yes.
explain about the mechanism of control for stress responsiveness?
Stress. This one. Is this the slide that we are talking about? Response of neuroendocrine response to stress and exercise.
A bit back.
A bit back. No, there's nothing here.
Oh.
Here. Metabolic response to cortisol during acute stress.
Sure.
This one.
Sure. Yeah.
Okay. When we talk about stress, acute stress, so even when we are having exercise is basically a stress. Any change to homeostasis in our stress, which means that even a light exercise and you go out, just go for a walk or running, it actually affect our body system, that affect homeostasis. As long as it affect homeostasis, we call that as an acute stress. But usually our body system will try to regulate back the anomalies that happen. So during just normal walking, you have a reduce in glucose level because you use out the glucose level. So that will be a response basically to increase cortisol secretion. When cortisol level increases, it's going to affect your liver to produce more glucose, glycogenolysis, and also glyconeogenesis. It's during acute stress. Okay, stress happens even interdigestion. That means before even we don't eat anything. That means between the lunch or dinner. So basically, this is the period where we are considered stress. Okay, these are all acute stress. Is that okay?
Okay.
Anything you want to ask about this that you are not clear of?
Doctor,
Yes.
I have a question. All the syndromes we've talked about, the Cushing syndrome, Addison's disease, will we do them again during pathology?
Yes, you will learn about in pathology, but this is just to show you that is when there's a high cortisol level. So you will do that probably more detail on pathology.
Alright, thank you.
So what you need to know is basically difference between Cushing disease and Cushing syndrome. As I say, is that just repeat again that Cushing syndrome is any condition that can cause excessive cortisol level. Okay, not people who are under inflammatory treatment. That means they take external source of cortisol. Basically, they use dexamethasone. They consume dexamethasone or even some herbal drugs. They actually spike it with cortisol or dexamethasone. That's why people who take herbal drugs and say these are organic or natural products, they are being spiked with cortisol. So they actually have high cortisol level. Now, what happens when there is high cortisol level and they found it, and then later they want to sort of the herbal drugs? They cannot. They are going to cause what we call the crisis. Cortisol level will suddenly drop to a very much low level. It can cause hypoglycemia. So you have to be very careful when you have a patient and you treat them with cortisol. So you cannot immediately take off from the drugs. You have to slowly step it down in lower and lower drugs later on. Okay. They have round face, moon face, buffalo hump. If they are over a long period of time, they show all these signs and symptoms of a Cushing syndrome. Okay. Any other questions before I pass it back to Liana to explain to you on the IRAC? No?
Doctor, one last question. So metabolically, the effect of cortisol and the effect of epinephrine or epinephrine is the same, right?
Yeah, in a way it's the same, but you look at cortisol mainly is to increase the glucose level. Even epinephrine, it do glucose level, but epinephrine actually utilize the glucose.
All right, thank you, doctor.
Yeah. Okay, Dr. Liana, I think if no question, I'll pass back to Dr. Liana to give you the feedback on IRAC.
Okay, thank you, Dr. Hafiz.
Okay, thank you, Dr. Liana. You want to take over now?
Okay. Can you see my screen?
Yes, Dr. Liana.
All right, okay, sorry. Okay. So we discussed on the first question. During stressful situation, how does the hypothalamus influence the adrenal gland to secrete stress hormones? A. Epinephrine is secreted via hormonal influence. Cortisol is secreted via hormonal influence. C. Aldosterone is secreted via renin-angiotensin system. D. Neuronal norepinephrine is secreted via hormonal. What do you think is the answer?
B.
Yes, B. Cortisol is secreted via hormonal influence. Why is C wrong?
Well, doctor, are the slides actually shown? Because I can't see the question.
Doctor, I can't see your slide.
I'll see the slide now. Can you see now?
Yes.
Okay, yeah. So, yes, the answer is C, but I'm asking why C is wrong. Why is during stressful situation, how does the hypothalamus influence the adrenal gland to secrete stress hormones? And C, aldosterone is secreted via renin-angiotensin system is not right.
Because aldosterone is not primarily affected by ACTH.
So, yeah, you are right. So, if it's by hypothalamus, then aldosterone is secreted via ACTH, but even that, the effect is very, very minor. Why is it so?
Because of the enzymes for the synthesis of aldosterone is not affected by ACTH.
Yeah. Yes, you're right, Austin. Good. So next question. Causes A, a rise in plasma volume. B, decreased renal excretion of potassium. C, hyperpigmentation of skin. D, metabolic acidosis. What is the right answer?
A.
Yes, good. The rise in plasma volume. What causes hyperpigmentation of skin?
Melanocyte stimulating hormone.
Yes, and which hormones that we have learned so far that causes that?
High levels of ACTH.
Yes, you're right. Yeah, so the hyperpigmentation of skin is actually due to when you have primary adrenal insufficiency, where you have high level of CTH, then it will cause hyperpigmentation of skin. Whereas oversecretion of aldosterone, what is the function of aldosterone again?
Sodium regulation.
And
the production of sodium pumps and potassium pumps and sodium channels.
Yeah, so what will happen is that there will be increased in secretion of potassium and
increased sodium absorption and water.
Water, yeah, that is why you have rise in plasma volume, right? Now you should have actually increased in renal excretion of potassium. Whereas D is absolutely wrong, lah. All right. Okay. Any question? Anything that you are not clear? Okay. So I guess
if not, then we are done with this module. So now it's around 10:30. Can we start at 11?
Yeah.
7 for the next module. Okay, yeah, we start at 11. I'll see you at 11 there. Thank you.
All right, thank you. So people will see at the next channel, yeah?
Okay, thank you.
All right, thank you all.
Oh, all right, Doctor. Thank you, Doctor.